So hello again. So this time we'll talk about perfusion and total antegrade perfusion, which is basically our center's philosophy in managing a minimal invasive approach. We'll start back from 2010. At that time, the minimal invasive the ESMIC Society stated in a consensus that minimal invasive surgery may be a good alternative in terms of short-term and long-term mortality, in-hospital morbidity, reduced external complication. But the problems still debating were stroke, aortic dissection, and minor complication as phrenic nerve palsy, groin infections, and obviously the prolonged operative technique. So we'll try to understand exactly what is true, what is changed across the years. Our detractors, I said ours because I'm part of the minimal invasive, let's say, fan, says that it is too complex, very difficult learning curve, and many of them says that we have experienced too many neurological complications. But exactly what is the incidence, or at least the real incidence of neurological complications in minimal invasive. Back in 1998, an initial results from the Leipzig group showed a worrying number, stating the neurological complication in 25% of their patients. But just a couple of years after, second year experience showed completely different results in terms of aortic dissection and neurologicals as stroke, hemiplegia, and convulsion. So 5 to 8%, which was becoming acceptable. Modern results starting from 2008 from the same Leipzig group decreased again the risk of neurological complication, reporting 3.1 in 41 patients out of almost 1,400. This was our single institution experience, a paper in which we actually wanted not stating the complication, but exploring the departmental quality control. We use QSUM curves. We divided our experience in many surgeons which have been involved in the last 10 years in minimal invasive surgery, especially mitral. You can see here separated by simply letters, seven different surgeons with different experience on a total of almost 100 patients. So in an institution in which we had a continuous training program in which youngest surgeons are trained and are assisted by more experienced ones, we stated a complexly 1.5% of stroke. So what is the conclusion? That increasing the experience, the lower is the incidence of neurological complication. So this is probably a way to better understand the problem. Then are actually more frequent in minimal invasive or in sternotomy, neurological complication, as many says. The same group of Leipzig, Professor Morse compared minimal invasive versus sternotomy approach in mitral valve surgery and compared to propensity matched population. Actually, they didn't appreciate any consistent difference between the two groups in terms of stroke, at least. Michael Argenziano from Columbia University, in another propensity analysis, stated that there was actually no difference from sternotomy and minimal invasive results in terms of stroke before and after 24 hours between the two groups. So actually, in another meta-analysis made by the Randolph-Chitwood group, no other significant difference was detected. So on a meta-analysis of 6 eligible studies, no significant difference. So we can actually state that neurological complications is not a procedure-related problem. It's not a procedure-related complication. So since there is no evidence of an increased risk, is this probably a time for a big multicentric randomized trial? But this is probably something we'll have to face in the very next future. So why there should be an increased risk in minimally invasive mitral valve surgery? Incomplete dearing could be responsible. Prolonged cardiopulmonary bypass and cross-clamp time, well, I don't know. And aortic balloon clamp, as we'll see afterwards, or retrograde arterial perfusion strategy. Surely retrograde arterial perfusion could increase the risk if in patients in which we could provoke atherosclerotic plaque mobilization or cerebral microembolization. It is actually a less physiologic flow. This paper from the Calvin Galloway group considered the evolution of the operative techniques and actually stated as, from a multivariable analysis, stated as a risk factor for neurological event significantly different the retrograde arterial perfusion itself. Another sign of impact of retrograde perfusion, we had it from a study we in our center performed in a number of almost 1,300 patients. We had evidence of a significant difference between anterograde and retrograde arterial perfusions in terms of stroke, transient or permanent, and post-operative delirium. And our multivariate analysis identified as risk factor for delirium right anterior perfusion itself. Talking about endoaortic balloon inclusion increased the risk. I have to say that we, at the beginning, started with the endoaortic balloon, and we very, very soon abandoned it for its complexity, for the need for a very dedicated multidisciplinary team, for many complications we, at least in our hands, experienced at the beginning of our experience. So we completely abandoned. And these probably were the problems we could have experienced after some years. So arch vessel occlusion, aortic dissection, and instability of the balloon, which has to be continuously monitored. But another paper from Cheatwood group said that permanent stroke seems not to be related to the use of endoclamp, at least in this large series of patients. And even Bonaros from Innsbruck says that no big difference have been reported in terms of stroke, but more in lymphatic fistula, actually. So endoclamp has not to be considered an enemy. But what can we do to prevent neurological complication in minimally invasive? We usually add CO2 insufflation, which on which many centers agree, many others don't, but I don't think that's crucial. But we absolutely implant an aortic root vent until the end of the procedure, because we've seen that the airing could not be complete just until the end. We always monitor the heart with the ECO-TE, and we try to standardize our de-airing protocol, trying not to hurry up in the procedure. And coming to the perfusion strategy, we always try to put a central aortic cannulation whenever possible. And obviously, we avoid retrograde perfusion in some kind of patient in which we have peripheral vascular disease, elderly patients, or if we have an evidence of descending aorta atheroma. We always scan with the echo or CT scan before the patient which are suspected to have some some comorbidities, and we try to avoid the endoclamp. We always use it, or at least we're ready to use it in redo cases. So what are the two different points of view? So antegrade perfusion reproduces our standard surgery, helps us to make the things as we used to do it in sternotomy. It is definitely more physiological. You don't need any patient selection or spatial imaging to select your patients. In contrary, femoral, femfem, let's say peripheral cannulation is a good alternative in difficult exposure. We recently moved to consider it in a very young patient with very small aorta or very thin aorta, or Marfan cases, or we consider it for aortic valve replacement in a patient with very short, let's say, access to cannulation clamp and opening the aorta. So, but it's a good option for beginners as well. So, but you actually need femoral iliac imaging, and you have to put some care during the Ehring procedure. This is our setup. Small mini thoracotomy at no more third, now very lateral fourth space, soft tissue retractor, 2 ports for camera and CO2 and vent, direct ascending aortic cannulation, always percutaneous femoral venous cannulation, as I showed you before, direct close clamping through the same access with anterograde cardioplegia and obviously a left atrial retractor through the very anterior third intercostal space. Femoral venous cannulation is something that made a lot of difference between before and after when we considered the minimal invasive. We still are using in any minimal invasive approach we have other than mitral. We use a single multi-stage for aortic valve replacement, or double stage in case of concomitant tricuspid procedure. We had an initial experience with jugular cannulation, which we decided to abandon because it was actually too tricky, too difficult, and too prone to problems. It is always vacuum assisted, and even in mini sternotomy allows a smaller incision. Our advice is to always check for central venous pressure during LA retraction, because in case we didn't insert enough cannula into the superior vena cava, LA retraction could dislodge it. This is how to perform it. This is the procedure. We put the guide wire in. We show how the CT, the T scan is okay, and here we insert after dilation, a progressive dilation, the cannula, always under TE scan. It is very important to be sure where is going the guide wire and if the cannula is well positioned after the guide wire removal. Okay. What about the direct aortic cannulation? We recently we started with that cannula with the blade inserted. I showed you in the video this morning. But now we are using this this cannula with a rigid tip, a very thin structure, and extremely flexible, very easy to be inserted through the same thoracotomy. So we have anterograde flow, unrestricted flow, because it is a 23 French, which reaches very high flow even for big patients. We do not give any additional incisions because the cannula goes through the same thoracotomy. with very low interference in surgical field. No interference is not correct, but let's say this it's very minimal. We do not select the patient, or at least we select as we did in sternotomy. We don't need any special imaging, and this kind of cannula, which disperse the flow without blowing directly through the aorta wall, could help in reducing plastic dislodgement. And as you can see, direct aortic cannulation, it's a procedure we do in any of our minimally invasive procedure. This is a mitral valve repair. In here we open the fourth space, the usual femoral cannulation, percutaneous cannulation. This is the procedure. You simply cut a little hole and then you push the cannula inside, having it secured by the usual two purse strings around. And once you have the whole aorta free after going on pump, you find a place to clamp and then you administer cardioplegia, free to open left atrium. This is mini thoracotomy AVR. You probably remember it from before. The thoracotomy allows probably an easier access to the aorta in this case, because the aorta is closer, to perform technically the same procedure. A little hole and then we push. Well, that was quite brutal, but... And we have enough space to cannulate superior pulmonary, right pulmonary vein. This was a very, very old procedure with a very, very old spreader. Okay, and then we're ready to open the aorta. And lately, with the new experience of mini thoracotomy, mitral and aortic valve replacement, many things changed, but not the perfusion. So we still are cannulating aortic ascending aorta, as you can see here, free to proceed with all the rest of the operation in the normal fashion way. But we have to admit that femoral arterial cannulation is still the preferred size in many centers which use minimally invasive cardiac surgery, so because it's easy and fast access. Some says that provides appropriate unrestricted flow, but you have to correctly match cannula to the patient you're working on, and you have to be sure about having good vessel, not very small arteries. But always you have to need to for preoperative imaging. Many are the limitations and drawbacks. You're not free from complication. You're not free from risk of dissection, peripheral neuropathy, discal ischemia, arterial emboli. Many are the potential problems, more or less. What we should avoid in cannulating peripherally is cannulating small size vessel, especially in big patients. A mismatch from cannula to body surface area has to be avoided. Atherosclerotic arteries, tortuous arteries, and obviously patients in which we have proof of thoracic over abdominal aneurysm. So select the patients. What are the tips and tricks? We usually go, if we go femoral, we go the opposite side from the venous side. So we go one side percutaneously, the other side we go with the arterial line, just to minimize groin complication. We always try to choose the right cannula for the patient. We always introduce it with Seldinger technique under echo guidance, and we slowly start CPB. In case you need an arterial cannulation, especially in young patients, the way to minimize the invasiveness of the procedure could be this. We recently started in selected patient percutaneously inserted arterial cannulation, which we did inserting first of the implant of the cannulation this ProStar device to the arterial closure after the removal. This is the device which has been retractor. We implanted the needle inside the artery already. We have four wires outside. We remove the device. We dilate, following the guide wires. We dilate the artery. And this is a 19 French cannula, new concept cannula from Medtronic. It is called Next Gen. And it comes very, very softly in position, as you can see. Once we have connected it, we can remove the compression and we're free to connect the line. When we remove it in this percutaneous procedure, we simply wash the area. We hold the suture, making some knots in advance. And the device allows us to remove completely the cannula with the bloodless fields at the end. And what we have to do is to tie the knots with this black additional tool, which should help to reach the aorta closer than your fingers. And once you're finished, everything is bloodless, and just 1 centimeter or maybe less of skin is left open. So, regardless of your perfusion strategies, your philosophy about going antegrade, retrograde, what we think is important is to have a good selection of the cannulas to correct match the patient for the access you chose, for the procedures he has to be treated with. So if you master in a proper way cannulation sites, techniques, and you have a good armamentarium to provide the best perfusion strategy for your patient, this definitely will improve your patient outcome in minimally invasive. Thank you.